succeed.
And Stu, you want to introduce yourself?
Yeah, hi, I'm Stu Levitz. I have 35 plus years of experience as an infectious disease physician. I was very much involved in my hospital, UMass Memorial Hospital's response to the COVID surge that we have, and I'm still very much involved in the response. My two children made it through the public schools, but are now out of the public schools. But I do have a strong commitment to public schools, and any way that I could help, I would be very much, it would be a privilege to help.
And Natalie?
And my name is Natalie Kong. I am a primary care physician at the MGH Revere Health Center. I've been working there since 2013 when I was a resident, taking care of the community of Revere. I am also the chair of the Board of Health of Revere as of this year, 2020. Great year. While I do not have children of my own, I am a product of public school education. I went to Everett High School. I'm also the product of two parents who immigrated here from Cambodia. So I definitely know the importance of an education. And I'm hoping to continue that education for all the students in the Revere public school system. And hopefully we can all work together to do it safely during these weird times.
Great, thanks, Natalie. Diane, shall I just start with my my presentation?
Yes, please do.
Okay, so I'm going to share my screen here. Let's see. So I've put together a hopefully short presentation on the basics of COVID-19. And so COVID-19 is due to a coronavirus, and coronaviruses are one of the causes of common colds. There are actually 4 human coronaviruses, and you can see from this graphic here that they're very seasonal, and they don't come every year, but they tend to come in a seasonal manner, and they're not particularly dangerous to us, unlike SARS-CoV-2. So coronaviruses account for about 1/3 of seasonal common colds, and we don't really know why they keep on coming. We don't know how long people get immunity when they get a coronavirus infection, but these are things that, of course, are of great importance. Whoops. So SARS-CoV-2 is one of several coronaviruses that have infected man. The 4 that I've already mentioned, the 4 human causes of coronavirus infection and common cold. SARS was an epidemic form of a coronavirus that occurred in 2002, and I'll talk about that more in a minute. And MERS, Middle Eastern Respiratory Syndrome, is a coronavirus that still exists in the Middle East. It's an infection of camels that somehow finds its way into humans. The actual reservoir for coronaviruses is the bat, and actually bats are thought to have several thousand types of coronavirus, each one of which may be the cause of human disease one day. So SARS, I mentioned, was the cause of our last pandemic coronavirus. That pandemic occurred in 2002. And SARS occurred, we think, because a coronavirus jumped from the horseshoe bat to something called a civet, which was sold as food in the marketplaces in China. And that civet somehow came into contact with humans and gave humans the disease. By the end of the epidemic, which was in June 2003, they had 8,422 cases, and the case fatality rate was 11%. So this was a very severe pandemic. We don't know actually what the relationship is between bats and animals that are sold in market for food and human disease in the current pandemic, but we think that there is also some type of intermediate that was sold as food in the market in Wuhan. Indeed, Wuhan was the source of the current pandemic. This is a city in central China. It's the capital of the Hubei province. And in the end of December in 2019, the WHO country office was informed that there was some type of pneumonia going around in the city of Wuhan. By the 7th of January, Chinese authorities had identified a coronavirus as the probable causative agent, and the disease was ultimately named COVID-19, and the virus was called SARS-CoV-2. In December, it was confirmed that humans could give the disease to humans, so there was human-to-human transmission, although this wasn't actually reported to central Chinese authorities until January. The Chinese were very quick to scientifically establish that SARS-CoV-2 was the cause of the disease, and on the 10th of January 2020, they actually published the complete RNA sequence of SARS-CoV-2 online. That did not escape the attention of Dr. Fauci at the National Institute of Health, who on the 11th of January, one day after this sequence was published, initiated a vaccine task force to work on coming up with a vaccine for the disease. Now, SARS-CoV-2 is often called a respiratory virus, but in truth, it affects virtually every organ in the body. Death due to COVID-19 can be due to pneumonia. In fact, that's the usual cause, but it can cause heart attacks. It can cause inflammation of the heart, as one of our Red Sox pitchers found out, unfortunately, this year. It can cause strokes. It can cause kidney failure and other reasons for death. The transmission is via respiratory droplets, like other respiratory viruses. And when the virus comes in contact with your eyes, your mouth, or your nose, or it gets breathed in, it can cause infection. And there is evidence now that transmission can occur from people without any symptoms of the virus whatsoever. So those people we call pre-symptomatic patients, that is, they haven't gotten sick yet, or asymptomatic patients, people who don't get sick at all. So you can see in this photograph here that where we come up with the 6-foot rule that I'm sure many of you have heard of, we know that these big droplets that occur with a cough or a sneeze mostly fall out within 6 feet from a cough or a sneeze. I'm not sure why my slides aren't advancing here. Sorry, I'm having trouble advancing the slides. Let's try this. Let's see if I'm sorry, my screen has stopped. Can you all hear me?
We can. And if you want to stop sharing, Doug, I have your slides. I can try to share them.
Well, my computer won't even let me stop screen sharing. Is there any way you can kick me out of this?
I can try to.
I can do it. This one's sharing. Huh. I'm trying to do that. Are you having any luck, Diane?
I'm clicking stop participant sharing, but it's not working.
Tell you what, I'm going to log off and then log back on again, okay?
Okay.
Sorry.
It's okay. We'll wait a minute for you. I don't know if.
Okay. Can you hear me?
We can hear you and we can see you. Do you want to try sharing
Okay.
again?
Fortunately, I'm on another computer.
Okay. I'm
me-
going to make you a co-host.
Okay. Let me get rid of that. And all right. And I'm ready to share my screen again. Okay. So can that be seen by everybody?
Yep.
Yes.
Okay, my apologies. So as I was saying, you can see from this picture here that this person is coughing out these big droplets. The large droplets travel very little distance and fall to the ground, and the smaller droplets travel further. And almost all of the droplets are gone by 6 feet. So when the virus comes in contact with your eyes, your mouth, and your nose, it can invade the body and cause infection. And unfortunately, about 40% of individuals who get infected by SARS-CoV-2 are either infected by somebody who doesn't yet have symptoms or somebody who will never have symptoms, the so-called pre-symptomatic and asymptomatic phases of the disease. Wow. Okay, so where are we now in terms of SARS-CoV-2? So this is a dashboard from Johns Hopkins University that is from a few days ago, October 3rd. And you can see that the world has nearly 35 million documented cases of SARS-CoV-2 and over 1 million people have died. In the United States, it hasn't been quite that bad, although we do lead the world in terms of the number of people who are dead. You can see from this colored map here where the hotspots are in the United States right now. We see hotspots in the Middle West. This red area here is Wisconsin. Some areas like North Dakota and South Dakota, and Massachusetts seems relatively good. Here we can see the positive cases on a monthly average. They really peaked over the summer and then came down, but really have not flattened out at a number that we would consider to be acceptable. Massachusetts is reopening in a 4-stage approach, which many of you have heard of. We started with a stay-at-home phase, and then we've already moved to phase 3, at least most communities are. And this is a phase that some communities like Revere and Chelsea, for example, are in and are not going to move beyond, at least until their numbers are a little bit better. And right now, I guess it's safe to say that the trends are a bit uncertain. We had been getting slowly a little bit better over the course of the summer, but in the last couple of weeks, we've seen an increase in the rate of positive testing, and an increase, although not so dramatic, in the number of people who are hospitalized, an increase in hospitals that are using their so-called surge capacity, and although deaths so far have remained fairly stable. And that may be because mostly older people die of SARS-CoV-2, and the current people who may be infected may actually be quite a bit younger. Now, one of the concepts that's very important in this disease is called the rate of transmission, or the RT. And this is basically a number that tells you how many people are going to get infected by every case. So for example, if you have an RT of 2.4, that means for each case of COVID-19, another 2.4 people will get infected. And very rapidly, if that turns out to be the case, you'll get a spike in the number of cases. If your RT equals 1, that is for every patient who gets infected, only one more person gets infected, there's really no change in the total number of people who are infected at any time in the population. And if your RT is less than 1, that's our goal, then the number of cases starts to fall off until you hit 0. So what this means is that every time we prevent even one person from getting disease, that makes a big difference. So in this cartoon here, you can see this person infected these 2 people. That would be an RT of 2. And they in turn infected 2 people who infected 2 people and 2 people. And there were a whole number of people who end up getting infected. But if we can stop this one transmission, so this person here doesn't get infected, we have a dramatic effect on the population at large. So there are a lot of measures that you can take that many of you have heard about already, but bear repeating. First of all, it's very important that we stay very clean. Wash your hands, because when virus gets on your hands, you can transmit it to other people or to yourself. So wash your hands with soap and water, and we recommend at least 20 seconds. An alternative to hand washing is to use a sanitizing hand cleanser. Do not touch your face. This is easier said than done. It's very hard not to touch your face. But if your hands are, if they are covered with any virus, you can introduce the virus when you rub your nose or you rub your eyes. Physical distancing to avoid exposure is very, very important. And based on the types of photographs that I showed you earlier, we think it's especially important to stay more than 6 feet from people. And if you're within 6 feet of an infected person for 15 minutes, you have an enhanced chance of becoming affected. Avoid gatherings of people. We generally tell people never to be in a gathering of more than 10 people. Avoid anyone who's coughing or appears ill. And this is a very important one. If you're sick, don't go to work, don't go to school, stay home. So, let me just summarize the things that we think protect against COVID-19 transmission. There's physical distancing, stay more than 6 feet away from other people. I'm going to talk a little bit about face masks. We believe those are very, very important. And eye protection, especially if you're dealing with somebody who you know or you think is infected. Protecting your eyes from droplets entering your eyes is very, very important. Okay, so masks really do work. We know that not only the N95 respirator masks that doctors wear, but these simple surgical masks or cotton ply masks that have 2 or 3 layers of cotton reduce the transmission of SARS by 60% or greater. Now, what are the types of masks that are available? Well, we have surgical masks, and you can buy these now in the CVS or any other pharmacy. And they are primarily meant to protect the environment from the wearer. So, for example, if somebody has SARS-CoV-2 infection, we like them to wear a mask so they don't generate droplets and aerosols that can infect the next person. But they do protect the wearer as well, although not as well as these respirator N95 masks. And you can see one of the more popular ones here in this picture. They fit very tightly to your face, and they protect the wearer from inhaling droplets in the environment. So here are the guidelines to using a mask properly. First, before you touch a mask, you should wash your hands. You should try and only touch the bands or ties of a mask when you're dealing with it. And you want to make sure that the mask fits snugly over your nose and your mouth and chin. Make sure you can breathe comfortably through your masks. And if they're cotton masks, make sure that you keep them clean. You wash them on a regular basis. Don't touch your child's mask while it is being worn. Don't wear your mask underneath your hood. Don't leave your nose or your mouth uncovered. Don't remove the mask while you're around other people. And don't share your mask with family members or friends. Now, we think that these type of precautions, the masks, the distancing, etc., are really our best defense in keeping our schools open and protecting viral spread in our schools. Masks have a big effect. We think that they drop the RT value that I talked about before a great deal. They have the biggest effect, but social distancing is important as well. If people remember to stay home and don't go to school or to work when they're sick, that's important. Screening has a small importance, and then there's ventilation and cleaning. And we really can, I believe, using these social measures, get our RT less than 1 so that the disease disappears. Well, what about testing? We believe that viral testing will provide objective data that our precautions are working, and in turn can provide reassurance to students, families, teachers, and staff that our schools are safe for in-person education. Most transmission occurs in people without symptoms. Hence, surveillance testing can help very much. So here we have a bar graph of how much of the disease comes from symptomatic people, how much transmission comes from pre-symptomatic, and how much comes from, say, the environment or asymptomatic individuals. And we see that an awful lot of transmission occurs from places where you wouldn't be expecting to get disease. So together, the Wellesley school system, the Revere school system, the Brookline school system, Somerville school system, and the Chelsea system have put together a pilot for COVID-19 testing. And this is a pilot that's going to be used to do surveillance testing on our children and their teachers during the school year at regular intervals to try to keep our schools safe from outbreaks. It won't stop all COVID-19, but hopefully it'll stop outbreaks, and that means our schools can stay open. I'm not going to go over this because I think I've run out of time, but there are many types of tests that we're considering. Antigen testing is being considered strongly by the state at the current time, and many people are considering doing pooled tests where we take tests from several kids and put them together and test them in batches as a way to identify outbreaks. So at that, I think I'm going to stop. We think we're going to get funding for our pilot program, some from the state, some from private donors, and even possibly from federal dollars. So I'm going to stop there, and I'm going to turn this over to, oops, I don't want to leave the meeting, do I? I'm going to turn this over to Dr. Ingalls.
And just while Robin brings up her slides, I'll mention that Watertown has joined the coalition. So we're actually 6 districts, and we don't anticipate that we'll start testing until we're ready to actually bring kids back to school in the building. And we'll talk a little bit more about that later in the presentation.
Okay.
There we go.
And Dr. Okay.
Oh, am I unmuted? And tell me, are you seeing my the correct version of my slides?
Yes.
Okay. So I am Robin Ingalls again, and I'm going to shift gears a little bit from all of the science we just reviewed and talk more about the challenges of reopening our schools and trying to bring it specific to Massachusetts and our local communities. All right, I'm not advancing. Here we go, try that. All right, so just to remind everyone how we got to this place. So on March 17th, all elementary and secondary schools were ordered closed in the Commonwealth of Massachusetts as a statewide plan to try to combat the spread of COVID-19, which at that time was starting to head towards its peak. And the closure was later extended to last through the end of the 2019-2020 school year. And here we are back in the fall, trying to get our kids to school again. So there are many impacts of having schools closed. We heard from Doug about the science of COVID, so we know some of the concerns, but there are clearly a lot of problems with keeping schools closed. And I don't think we should underestimate the impact of closed schools on child and adolescent health. We know that isolation can lead to increased anxiety and stress. And this is certainly going to be amplified in our children if they have fear of getting sick, if they have grief from a family member who got ill, possibly died, or if they're concerned about their parents losing their jobs. Social connections for children and adolescents are really essential for development. And this is true across the age span. So our youngest learners are really navigating how to interact with other people, and our adolescents are also developing different types of relationships. We know, actually both for children and adults, that loss of a routine can really lead to disrupted sleep patterns and poor eating habits. And the closing of schools really had a significant impact on children and adolescents who have special needs, because these are our most vulnerable learners, and when they're not receiving the necessary services they need, they are going to be unable to meet their academic and social goals, and we don't really know if they'll ever be able to catch up. Beyond the children, there are also significant impacts on families. As much as we focus on school as providing an education for our children, clearly we know that school is also an essential part of childcare for many families. We had parents trying to navigate their own complicated work schedules with trying to supervise their children in the spring who are having virtual schools. And as we even learned from tonight, there can be some problems with online platforms and problems with connections. Again, school closure was particularly a burden for essential workers. It was hard enough for parents who could work from home to try to work at home and supervise their children, but it was even harder for parents who had to work outside the home. And like many things that involve the family, women were disproportionately impacted by this need to split time between work and supervision of children, because women generally are more responsible for childcare. The other thing that's important to remember is that the COVID pandemic has unfortunately become a mirror for all the racial and socioeconomic disparities that we know unfortunately exist in our society. What do I mean by that? Well, there is a problem with a digital divide, that access to technology, to internet, and to space in a quiet area to work is not the same across the different towns, different cities. It's particularly a problem not only for districts that have high rates of poverty, but also for rural districts that might not have good internet. We tend to see an overrepresentation of essential workers in areas that have lower socioeconomic status. And again, job loss or loss of hours can lead to food and housing insecurity. There was an article in the Globe last month that reported increased calls to the state's Department of Children and Families during the spring remote learning because children were not logging on and were being counted as absent. And as much as this may have been well-intentioned by a lot of school districts, it was clear that it was not enforced equally across different districts. And there was an impact that was greater on high poverty districts and particularly Black and Latino families. So we know that getting kids back into school is going to be important, but we know that we face many challenges. As the school year starts, we have to decide if and how to reopen schools. And we have fairly limited data on the impact of reopening schools on virus transmission. And we need to consider three populations all at the same time: children, and by extension, their families, the teachers and staff who have to go to work in the buildings, and then the wider community where the schools are located. Unfortunately, there's no federal reporting requirement for COVID-19 in schools, so we need to find a way to gather data. I will say that Massachusetts is one of the few states that will be collecting data on cases that occur in schools. But even if we identify cases in our schools, we have to do a little more detective work to try to figure out if this is a case that was brought into the school from the community, or is this a case that indicates that there's spread from children to children or from children to teachers and back. Right now, with the data that we have, the most we can say is that when there's more COVID in the community, there's a high risk for more COVID in the schools. So how do we approach some of these problems? Unfortunately, our public schools are not on islands and we don't live in NBA bubbles. So we have to be able to keep children and teachers safe and do that in the setting of our own communities. So we have to look at local transmission and try to minimize the introduction into schools. And we need to set some bar, some benchmark to determine what level is too high for local transmission, that we are not comfortable sending our children to school. And we need to minimize transmission so that if a case is identified in the school, we have limited its spread. And we do that through the mechanisms that Doug already discussed, things like masks, physical distance, and ventilation, which means in many ways trying to keep kids outdoors as much as possible. So what is happening in Massachusetts? So this map should be somewhat familiar to everyone. I feel like it flashes every day on the evening news. This is the color-coded map for Massachusetts that gives each town a color based on the number of cases that have been reported per 100,000 population. I downloaded this map today, actually, and you can see that Boston has become a red city. So school districts waited all through the spring for some guidance to help them reopen, with the hope that there would be some detailed plan from the federal or state government. Unfortunately, that didn't happen, and partly that's because we're really learning as we go along. And of course, every community is different in terms of their needs and their population. So DESE, which stands for the Department of Elementary and Secondary Education, has been working with our State Department of Public Health to come up with guidelines to help school districts reopen. And what they first requested is that every school district come up with not one, but 3 plans. One, to resume in-person learning, but with safety requirements that would prevent COVID from spreading. A second, that would be hybrid learning. And every town has kind of interpreted hybrid learning a little differently, but it's where a student would learn partly in person in the schools and partly remotely at home. And then finally, remote learning, which would serve 2 purposes. One is it would provide a safe way for students to learn if they were too vulnerable to get from getting sick from COVID, so that they could be safer and learn from home. And also it would provide a better platform so that if the state has another surge and we are required to shut down all schools, that we will have a way for students to continue to learn at home until it's safe to return in person. And so across all these models, the state did also request that districts plan for special populations. So our learners who are vulnerable, to make sure that they have all the necessary services and accommodations. So the DESE guidelines tried to help towns determine what school platform they should use based on their metrics. And so you can see from this, this cartoon that if you are one of the cities in the red zone, you are recommended to have all remote learning. To the other extreme, where you're a green zone town, where you have less than 4 cases reported per 100,000 population, DESE wants these towns to go full-time in person, or if there are extenuating circumstances, they can be hybrid. And you'll see when we talk about some of the other guidelines that a lot of towns are really strapped with having to be hybrid because they just don't have the infrastructure to be full-time in person. And then of course, in between would be the towns and cities that would do a hybrid approach. The safety strategies that were recommended by DESE are should be familiar. They're some of the things that Doug just talked about. So one is to wear masks or face coverings. And people might ask, well, what's the best type of mask to wear? And honestly, it's whatever mask you find comfortable that you can wear it through the day, whether that's at work or for your children going to school. There were not really details about who would provide the face coverings. Should it be the district that buys them? Should it be individuals? Should the district provide face coverings for all their staff and teachers? And so those decisions are really left to the individual towns. Physical distancing was a really important part of the DESI guidelines, and they wanted everyone to aim for 6 feet of space between all individuals when feasible. And of course, our schools just aren't big enough. Our classrooms aren't big enough to fit the 20 or 30 students in there 6 feet apart. They did say that you could go down to 3 feet apart, but even at 3 feet in my town, we can't fit all of our students in. So for the towns that really could go back to full in-person teaching, we just don't have the space to do that. Hand washing and hand sanitizing is key, as we already reviewed. Again, the problem with this is most classrooms don't have sinks. So if you can't hand wash for 20 seconds, then you can use hand sanitizer. And then the obvious, stay home when sick. And it seems like it should be obvious, but many of us have had the challenge of not being able to keep our child home if they have a runny nose or they have a fever, but we really, really need to do that now. We can't afford to have any COVID go into our school if we have the ability to stop it. Unfortunately, we do know that many people can start shedding the virus before they develop symptoms, and we don't really have a way to prevent those cases. So additional considerations that DESI mentioned in this guidelines that they put out, they stressed the importance of ventilation. So you don't have to have fancy HVAC capabilities and HEPA filters in your school system. Simple things like opening windows and opening doors can bring in fresh air. A lot of towns that have green space are trying to put up tents and trying to move at least some activities outdoors. That doesn't work for every town. Certainly cities that have less green space are not going to be able to take advantage of this. They suggest trying to maintain small cohorts of students. This might work better for younger children, but is a little more difficult for high school and middle school students that have electives that they want to take. Lunch is a big problem because the CDC recommendation was for students to eat in their classrooms, and obviously you have to remove your mask to eat. So you need to maintain at least 6 feet of distance. And we have to have a way for children to safely eat in their classroom or in their school if we're going to make them stay for a full day of school. And also for the teachers who are going to need to eat. Testing continues to be a big problem. We know that rapid testing of symptomatic people is really important and key for contact tracing and controlling the spread of the infection, but this is not always available. And it again highlights many of the disparities between different towns and cities in Massachusetts. Per DESI guidelines at this time, in-school surveillance testing is not recommended, but I think we can all see the value of surveillance testing if we can overcome the costs and the logistics. In terms of what to do when a positive case occurs in the school, and I think we all have to acknowledge that at some point when we open our schools, we're going to identify someone who brings in COVID from the community. We need to do contact tracing. And the current guidance from DESI and the Department of Public Health is that a close contact is someone who's been closer than 6 feet away for more than 15 minutes. So again, you can see the importance of schools trying to spread out their desks 6 feet apart. So when do we change our learning model based on those guidelines? So we can follow the number of cases per 100,000 population. So that's the color-coded map that the state releases. We can also look at the percent of positive tests. So these are the number of tests that come back positive for COVID. But there is a bit of a caveat to that, which is that we're doing a lot of tests now. We're testing a lot of college students. People are getting tested multiple times. So there are some people who would argue that we really shouldn't be looking at the percent positive tests, but the percent positive people. There's also an interest in looking at wastewater monitoring, which I think is really interesting, but we don't quite know enough about what it means. The MWRA is actually doing a pilot project to test sewage that goes to Deer Island, and they're testing it for evidence of the COVID virus. And we know that while COVID primarily is a respiratory virus, it can also infect the cells that are in the GI tract. And so it will be shed in wastewater. And it might be a way to have an early warning system that a surge is coming. Right now, we don't really have enough information to make that an ideal metric to follow, but it might be something to look at. The other thing that Desi really stressed is that you have to look over multiple weeks. So don't panic when things change over 1 week, but look over 2 to 3 weeks before you make a decision. And you probably need to look beyond your own individual town, because again, we're not in bubbles. And so we have surrounding towns and surrounding communities. We should look perhaps at the county level for what's happening, because we know teachers commute in and out of their schools, and we know that children have parents that work outside of their town. Again, COVID surveillance testing, I really think could be a way to better inform the decisions we make regarding, should we stay open, should we open more, or is it time to close down? Finally, as I mentioned before, Massachusetts K through 12 schools are required now to inform DESI when they learn of a student or staff member. You can actually find this information on the website that I have listed there. And I checked earlier today, and for the week ending September 30th, there were so far in the state of Massachusetts, 61 students that were in person or hybrid that tested positive for COVID, and 35 staff that have been reported to the state. Contact tracing and monitoring of cases is not the job of DESI. It remains the responsibility of your local Department of Public Health and the Board of Health. And again, I really can't stress enough what I think is one of the important parts of our approach to keeping COVID out of schools is this rapid turnaround time for symptomatic testing and testing of contacts. We really need this to control viral spread. And with that, I will attempt to stop sharing my screen.
I wonder if I can just override and share my screen. Oh, I can do that. All right. Thank you, Robin, for that wonderful presentation. I'm going to bring it home by going over the numbers in Revere, just so we can take everything that Robin just went over and put it into perspective regarding what is going on in our city. Obviously, there's a lot of different gray, green, red, yellow, areas and communities in the state of Massachusetts, but what's happening in Revere? This is where our case counts are at right now. This was the peak over here back in the springtime. And for early in the summer, our numbers were looking pretty good, but we experienced a bit of an uptick late in the summer, and we've kind of stabilized a little bit. Our average case count is about anywhere between 12 and 15 new cases per day of COVID in the city of Revere. This is our 14-day positivity rate. I'm going to go over the importance of this in just a minute, but it does pertain to school reopening. As you can see, in the month of September, we have been slowly getting our numbers down below 5% and maintaining it over the last couple of weeks below 5%. And this is down from a peak of about 6.3% way back in late July. Despite having a lower so even though we have a lower positivity rate, I think the great news is that our testing numbers have actually been going up and up and up. We have an all-time high of testing for Revere residents. I know that our Stop the Spread testing campaigns at the Revere High School and by the beach, they're open to all folks, not just Revere residents, but these are the numbers that are coming from our residents alone. And we've had a huge uptick in testing, which is awesome. And thankfully that has equated to a lower case positivity rate. So I think we're doing as good of a job as we can in trying to stem the spread of this virus. Robin went over kind of the importance of school reopening, so I won't go over this slide very much. But something I also wanted to present, I presented this to the teachers about a month ago, and I pulled up some updated figures. These are the number of COVID cases in children collected by the American Academy of Pediatrics. They've been collecting this data basically for this entire year across most of the country. Not every state has been reporting this. I want to differentiate this from what Robin said a minute ago. Even though there's no federal mandate to report COVID in schools, this is different. This is just COVID across the board. Kids could be getting this in any context, not just schools. However, thankfully, as Robin also mentioned, Massachusetts is collecting that number. So we will have both just incidents of cases of children getting COVID in general, and then we can also see more of the nitty-gritty and how many of those kids are getting it in school. All right, busy slide. I want to point you to a couple of key numbers. One is the cumulative number of COVID cases in children or in patients less than the age of 19. That's what they're going by. There's been almost 625,000 total child COVID cases reported across the United States. And this represents about 10% of cases overall. So of all the cases in the United States that have been reported, 10% of them are happening in children. The good news is that of all the children who had COVID, anywhere between 0.5 to 3.7% were reported to have been hospitalized. Between 0.2 to 7.9% of all childhood COVID cases resulted in hospitalizations for COVID. And then the next segment is mortality. So 0 to 0.26% of all COVID-19 deaths were in children. So thankfully, though the number of COVID cases is continuing to rise in the United States, and though we're still reporting cases here in Revere, across the nation, it seems that the severity is much less in children, and we're defining that by the hospitalization rate and the mortality. But where does Massachusetts stand in all that? Well, we are all the way down here. So overall, across the country, 10% of COVID cases are in children. But thankfully, in Massachusetts, we're below the average. As of September 24th, when this data was last published, 7.4% of total COVID cases in Massachusetts were in children. So we're doing a little bit better than the national average. 1% of total hospitalizations of the children represent 1% of total COVID hospitalizations for the entire state. And to date, there have been 0 reported deaths in children under the age of 19 who have had COVID. So just a little bit of perspective. Though our numbers are looking good, that doesn't mean we want to rest on our laurels. We're still going to take the utmost safety when considering reopening of our schools and going to any sort of in-person learning. Now, what does that mean? What does that mean? What does that look like? How do we successfully reopen our schools? There are a couple measures that DESE and obviously the State of Revere are looking at, and that is the number of cases per 100,000 people. We are in the red zone, which means we have greater than 8 cases per 100,000 people. We're actually about 12 cases per 100,000 people. We want to see that number obviously go to less than 8. We also want to see our case positivity rate be less than 5%. And as I mentioned before, we have been less than 5%, which is great, but we need both of these measures to look like that, and it must be sustained for about 2 or more weeks continuously. So where's Revere at right now? We're at about 12 cases per 100,000 people as of last Wednesday's data. We're at 3.82% case positivity rate, again, as of last Wednesday's data. And thankfully, our case positivity rate has been looking good. We've been at that goal for about 3 weeks, but clearly we have a ways to go in terms of the number of cases per 100,000 people. That's not our goal. So we won't be making any plans to reopen school until these numbers improve. And that's it for my end of the talk. I'm going to stop my screen and hand it back to Diane.
Thank you, everybody. And you know, in the next piece, we are going to take the questions from the Q&A and give the doctors a couple minutes to address each one. I know that they've been responding a little bit in writing already to folks as they submitted questions in the Q&A. But I do want to invite everybody to drop a question there if you have one. And just before we get to the Q&A, I'll just ask Dr. Levitz if you wanted to add. I know that your 3 colleagues had done the main presentations, but if there was anything you want to add before we move to Q&A.
Yeah, sorry, I was unmuting there. No, I think the Q&A, I think some of the questions that I saw in the Q&A and in the chat really had to do with inequities, and I wish there was more that we could do about it as a society, but I think we have to deal with the situation as it is and make the best of what we're being dealt with here.
Mm-hmm. Very true. So I'm going to ask Dr. Mokaba. I know that you've been monitoring the Q&A, and if you do want to just read the questions one at a time, and then the doctors can chime in. I know some of you already have, but others might have something to add.
Yeah, and I think Dr. Levitz just got at both of these a little bit. One question was, I'm just wondering what the difference is between going to a Catholic or private school in a red zone area. The Immaculate is in Revere, high risk, yet they are in school. Linfield schools are hybrid and they are in a red zone. This seems completely inequitable. And that was the most recent question. The other, can you explain why, if the CDC is recommending remote learning due to COVID numbers not flattening out, why are private schools in hotspots able to return to in-school learning? So both questions are along the same vein.
Yeah, so maybe I can actually tackle that one, and maybe the mayor can actually weigh in afterwards. It's a little bit of a political question, I think. Our public schools are bound to follow guidance from public officials and from the Department of Elementary and Secondary Education. So we do weigh very heavily the guidance that we get from the CDC, the Mass Department of Public Health, the Department of Elementary and Secondary Education, and use their guidance to help predict what our movements are going to be and what actions we're able to take. Private schools don't have the same kind of regulation or guidance that they're required to follow. They have a little bit more autonomy to do as they see fit. And I don't know if Mayor Arrigo, if you want to add to that.
Yeah, I'll jump in and say that while they do have autonomy and we've given them suggestions, and Dr. Kong knows that they've had a lot of conversation with the leadership at the Immaculate Conception, that we gave them, and we reviewed their safety protocol and their the things that they were going to do to in their mind, make the school a safe place. And while we don't have jurisdiction to say you can't have school in person, we took what they gave us in terms of their policies and their protocol and gave them recommendations on that, gave them feedback on that. I know there was a lot of work done from the city standpoint to have that conversation. But at the end of the day, we don't have the ability to say, no, you can't open. Now, if it were up to me, I would have said you can't open. But again, we don't have jurisdiction over that. And that was a decision that was made by the Immaculate Conception. All we could do is make sure that that they do everything in their power and that they're getting guidance from us to take necessary precautions.
Oh my goodness.
We have another question. My question pertains to the flu shot. My daughter will remain in remote learning setting this entire school year. Are we still required to give her a flu shot? Thanks.
I'm not sure how we missed talking about flu shots, but I'm sorry, I just, that must have just skipped me, but please get a flu shot yourself and please get one for your daughter. There are a variety of reasons for that, even in a non-pandemic year. But in this year in particular, having influenza can be confused with having COVID-19. And so, and having influenza can take up valuable resources that might be spent on a patient who has potentially lethal COVID disease. And we just want everybody to get their flu shot this year. I know you're asking, well, my daughter's going to be in the remote learning setting and it's not going to be mixing with lots of other kids. But in fact, your daughter will really interact with many more people than you realize, and we'll have the chance of contracting influenza. So I would certainly recommend that both you and your daughter and everybody else in the family get their flu shot this year. Anybody have anything to add to that? Was I strong enough?
I guess the one thing that I would add is just that the guidance that we've received from the Department of Elementary and Secondary Education is that students should have a flu shot by December 31st, regardless of what the mode of learning is, whether it's remote or hybrid or in person. And I don't know that we're in a remote environment looking to police that very much, but we certainly are strongly encouraging it. And the city actually has set up a flu clinic for children to get their flu shots at the Beachmont School, and there's going to be another one coming up at the Wayland School. And I don't know, Dr. Kong, if you have those dates at the top of mind, or I can look them up.
I want to say October 17th is the one for kids. For whatever reason, that's coming up to mind. There's October 17th, October 20th, and October 24th. And there's one of them that is specifically for kids. And we're also going to be giving other vaccines, not just the flu. So any other childhood vaccines that you're needing, we can provide. I don't know if you can double check that, but it's definitely one of those dates.
There's another question. How are you mitigating the risk of COVID prior to children returning?
Well, I can take a stab at that one. I guess kind of going along what Robin was saying and the information I had posted on that last slide. If there's COVID in the community, then we worry about COVID being in schools. So the number one thing to do before we even entertain a hybrid learning model, let alone a full in-person model, is getting our numbers down so that the density of COVID cases is not that high. And that alone will obviously hopefully mitigate risk of COVID being in schools. But the other things that we're doing are going to be kind of what Doug and Robin already said, and that's going to be following the DESE guidelines to try and keep kids greater than 6 feet apart, or at least 3, as long as they're wearing masks, and trying to, cohort the kids or try to reduce the density of the classrooms by maybe having kids come in on like an offset schedule, like some will come on this day, some will come on that day. That's kind of what the hybrid learning model is, where there are some days where you're remote, some days where you're in person. So those are things that will come kind of online once we get closer to a hybrid learning model. But in terms of what we're doing now to get ourselves to even to the point where we're less than 8 cases per 100,000 and a case positivity rate of less than 5% for 2 consecutive weeks at least, the usual social distancing, mask wearing, don't go into work or anywhere if you're sick. Please take advantage of our testing sites. The Stop the Spread free testing sites are going to be at the Revere High School parking lot, as well as the Marquee Footbridge over on Revere Beach Boulevard until October 31st. We do have plans to try to create a winterized testing site after October 31st. So stay tuned. We will have a testing option for everyone even after that date, but just do your best to try to prevent by using social distancing and masks and not going anywhere when you're sick. Get tested if you feel sick or if you feel like you could have come into contact with someone who may have had it. And don't forget about contact tracing. That's so important. If you do test positive, a contact tracer will call you. A trained person from the state will call you, and they're not looking to report you to anybody. They're not looking to shame you for getting COVID. All they want to do is get information about how you could have contracted it, so that we can prevent the next person from getting it, and we can get our numbers to a point where we can send our children back to school. So super important things to do and to keep in mind. These are all ongoing and hopefully will lead us towards a hybrid model, at least of schooling.
I should mention that Dr. Kelly and I met online today with Secretary Sutters, and there are plans to keep testing open, free testing open for the entire school season. Diane, do you want to comment on that?
Sure. Just briefly, and I know that Mayor Arrigo is aware of this, but the Secretary Sutters did talk about the super site or mega site, I forget which term she used, at Suffolk Downs. And I know that we had talked before about that being open through the end of January, and she referenced today that it was going to be open indefinitely. And I think we did press a little bit about the need to make sure that there was testing available right through the whole school year. Not just for Revere, but for all students in the Commonwealth, that they would have access to testing if that was necessary. And she said that there were sites, and that was one of them that they were looking at to have open indefinitely. So that was good news. And I can just on the clinics, and there is a notice that's going to go home to parents tomorrow about all 3 of the flu clinics that are being set up, the ones for adults and the ones for kids. I know the school nurses work today to finalize that. But the one for kids to get the flu vaccine or their childhood vaccines will be at the Beachmont School parking lot on October 17th from 9 a.m. till 3 p.m. And in the notice that will go home to parents tomorrow, this will be via email, and we'll also put it on the website. There will be a link where you can register so that folks know what kind of vaccines need to be brought for each child.
Diane, there is one question about vaccines that came up on the YouTube channel. It says that I'm hearing that, not vaccines, I'm sorry, testing. I'm hearing that rapid testing is not very accurate. What is the accuracy of the rapid tests?
I will defer to everybody else.
Well, Stu, why don't you start with that?
Yeah, the accuracy, the accuracy of the PCR test, which is not the rapid test, or the sensitivity is greater, but the rapid test detects people that are very infectious, and that it detects it very well. So there are advantages and disadvantages to the rapid test versus the slower PCR test. The slower PCR test will detect more cases because it will detect people very early on. It will also detect people toward the end of their infection when they're no longer infectious. If the antigen test is positive, it means that it's very likely that the person is infectious, and therefore that they should be in quarantine. And the main advantage really is that you can get results within 5 minutes, within an hour, and essentially in real time. If you do the slower test and it takes 24 hours or even 72 hours to come back, longer in some places, it really isn't, by the time you have the results, it's not that helpful.
Thank you. We have two questions that are both asking about our buildings. One of the questions was, sorry, should have asked how the schools are preparing the school buildings. Some of the elementary and secondary schools are on the older side. Are they ventilated properly? And if not, are they working on correct ventilation?
So I'll take this one, these two, I should say. So the schools are fully prepared to reopen in a hybrid model if we can get to a state where that's advisable. We have all of our PPE on site. We have set up our classrooms for roughly half as many kids as we typically would have at one time. If we're able to come back to a hybrid model, we're looking at doing a 1 week on, 1 week off, where half the kids come in on week A and the other half of the kids come in on week B, and the kids are learning remotely from home on their off week. So all of the information about that is in our reopening plan, which is on our website at revereK12.org. And that's been updated several times as we've had updates to post, and includes information like what the schedules look like right now while we're in remote learning. It is very much targeted toward remote learning right now because that's where we are, but it includes plans for what school would look like if we were in a hybrid model. So we're very well prepared if we can get to that place where the numbers say we should be back in hybrid, we're ready to go when that happens. In terms of ventilation, we did do some extensive testing over the summer, and we found that all of our HVAC systems were working well. The systems at the high school, at the Beachmont, and at the Garfield buildings were not designed to take in as much outside air as we would want them to. And Carl Svensson, who's our director of facilities, and our maintenance team have done a lot of work working with our consultants from Amoresco and also our airflow testers from Barrett Company to maximize the air intake from those systems. And we've also done extensive work. I think that you saw in some of the earlier presentations, one of the most important things is that we can bring in adequate air from the outside, and opening windows and doors is key. So we've made sure that our windows are operable. We continue to explore other options, such as putting MERV 13 filters directly in. We have already put those in our rooftop units, but we're looking at, in those 3 buildings, putting the MERV 13 filters directly into the univents, which will help clean the air. And Carl and his team are taking the lead on that work. It's an ongoing project to find alternatives to having to leave windows open in the winter months when we would prefer not to, because we want to be warm, but also because we want to be mindful of our utility bills as well.
I don't see any other questions in the Q&A or the chat.
All right, well, I will very briefly thank Dr. Kong and Dr. Golenbach and Dr. Levitz and Dr. Ingalls for your time tonight. I think this has been very informative and hugely helpful. And with that, I'll give it to Mayor Arrigo to say a couple of closing remarks. And his own thank you.
And I'll just quickly thank you, Dr. Kelly, for the amazing work that you've done. I know it's how difficult it's been over the last several months, but I know that a lot of folks are looking, a lot of folks in the region are looking to Revere and looking to your leadership. And I am appreciative of everything that you've done. And to the panel, thank you for taking your time. It is critically important that we have qualified medical professionals that are guiding us through making these decisions. And I can't thank you all enough for taking the time and putting your energy into what we're doing here in Revere. To everyone that's watching, thank you for participating. I know this was informative for me, and I feel like I've had I've been drowned in COVID-19 charts and presentations and information. But this was a great presentation and very informative, and I think it'll be very helpful for our parents to watch and to listen to. And so, thank you again for everyone that's taken so much time and effort to put this together. And I would say that if anyone has any questions, please don't hesitate to reach out to my office. I know there were some questions about the slides. We'll make sure that those all get published publicly, and if there's ever any questions or comments about tonight, please don't hesitate to reach out to me into my office. Thank you, everyone.
Thank you. And I'll just quickly say, Anne Marie put a question in the chat about parents getting a survey about remote screen time, and we will be working on another parent survey to gather feedback on how the remote learning is going and what we can do to improve that. So that will be coming probably in another 2 to 3 weeks. We do want to give a little bit of time for people to settle into the new system, but that will be coming. Okay. Thank you all so much. Have a great night.
Thank you. You too.